Good morning. This is really a big pleasure for me to be here again. You know, when I am in this part of the world, I feel like to be home because I see so many friends around me, people I met all the time in several meetings. But most important for me is that I feel that we are belonging to the same family, because this is the area with the first human community started in your country. And we should never forget that one. Also, you don't forget that one, all right? How important it is for the human being the existence of this part of the world in this particular area. So, of course, there are many, many historical, in the past, relations between us for our two countries in a very good and in a very bad way, but all the time we are very close together. And today I'm very happy to be here again. This is an honor for me to be invited. What I like to share with you today, I like to share my new technology now with a new ring I developed, because this looks to be a very popular issue in the last couple of years. I mean, how we deal with the capsule after we remove the cataract. There are many interests, let's say, in our days about it for several reasons. And just I share with you the presentation I have done last meeting from ESCRS in Milano, and this innovation has been selected one for the 3 most important innovations of the year. So that's why I like to share with you this technology. So, you know, there are many issues related with the lens capsule. One for the most important, which has been highlighted the last couple of years, is of course the exchange of the IOL, a future exchange. They had in the United States only for the 2019 about 12,000 cases for IOL exchange for many reasons. I mean, the major reason of the IOL exchange, of course, is to replace with the modern IOLs, and more often we face this problem also in pediatric ophthalmology. So also the precise IOL alignment looks to be very critical for the premium IOLs. So we should know exactly where the optic is placed inside the eye in order to make, let's say, the better calculation. Posterior capsule opacification is also an issue which still today existed, besides the fact that the modern IOLs, they are designed in order to reduce the PCO. But still today, if you look on the literature, it's about 10 to 40% of all procedures, they develop PCO and they need later on YAG lasers. Capsular fibrosis for the anterior part of the capsule, which generate phimosis and loss of the eye saturation and tilt, is also very important. In pediatric ophthalmology, we know that the exchange of the IOL is very often because of the miscalculation or because of the change of the anatomy of the eye. Lately, we understand much more about also the peripheral optics. And we know that peripheral glare is a problem with these high-end, let's say, premium IOLs. What we know also from the past, that in all our cataract surgeries we have the early subclinical macular edema because of the vitreous movement during the surgery. So the vitreous stabilization also is important in this case. Vitreoretinal surgery needs some challenges to be improved in the sense how we deal with the IOL and cataract in all these cases. And of course, a problem which we face from time to time is the rupture of the capsule, and we have to solve this problem. I would like to stay a little bit on the PCO etiopathogenesis, just to remind you that there are two types of cells that are generating PCO. One is the A cells and the other is the E cells. The A cells, they are the ones they make what we call late PCO. And they are doing, let's say, a direct fibrotic effect. And the A cells, they are in the anterior part, under the anterior part of the capsule. And they are the ones that generate the capsular fibrosis and the phimosis. The E cells, they are most in the meridian of the capsule, and they are the ones that are more active, and they are the ones that generate the posterior fibrosis, which or PCO, which is what we normally see on the cataract surgery. So mainly, let's say, the major problem for the old cataracts is the E cells, and for the pediatric, let's say, are the A cells. They have been designed several IOLs already the last decade just to fill the capsule. This is a type of, let's say, accommodative IOL. Just I show this one because this is a lens which is fitting inside the capsule and never works because of the capsular fibrosis. That's been capsule is losing the elasticity after a couple of months after the surgery because of the fibrotic effect of the cells. In our days, this ring is the one which probably is most approved to be used for the capsular rupture. This is today is FDA approved also, this ring, the CTR. They are very good, of course, to assist you to put an IOL when you have a capsular rupture after the cataract surgery, but they are not good enough to prevent, let's say, fibrosis, or they don't give you a future somehow to stabilize your IOL in the capsule. This is another type of open ring. The previous one was also an open ring. I had designed this open ring 15 years ago. We had done a very long follow-up study in the University of Crete for 35 cases with long follow-up. And the result was very impressive because the idea behind was to fill the peripheral capsule and to stay the capsule stays open. But still, these open rings, they don't fit all the time very well inside the capsule, so they leave sometimes a small gap between the end of the rings. And then the cells migrated through these gaps, so we cannot avoid 100% the PCO with the open rings. This full-size ring has been invented probably many years back, like more than 50 years back, for the Japanese guy. And the idea behind it was, of course, to fill the peripheral capsule in order to block the cell migration, but this design does not work for many reasons. So that's why I came to the idea, let's say, to design a special ring which has several features. And this is the ring how it looks like here. The ring is, when you see the video here, you see how the ring is adjusted inside the capsule. The peripheral part of the ring is more flexible, so it can be adjusted in any size of capsule. And the central part is more stable, this one here. You see here the two clips. There are two clips here, they are quite stable. So here inside the clips, you can click inside and lock your IOL in the very center of the ring. So these are images, Scheimpflug images. You can see very nicely how the IOL is centered in the middle of the ring here. This is the ring here. See here I have designed the ring on the side, how it looks like. So the capsule is stretched here very nicely, the posterior capsule, and you see the results later on. What is important here is that you remove a certain volume of the eye, which is the cataract, in the normal IOL. You don't replace the volume. That's why the vitreous is very floppy during the surgery. With the ring, you refill the whole space of the cataract, so the vitreous stick on the back of the capsule and it's very stable there. That's why we have very good results on the early macular edema using the ring. So up to now, we have done several studies in several places. The main study has been started in Alexandria in Egypt, and we finished the study for the CE mark application. But here in the slides, you see several places we've used the rings to demonstrate that you can use the ring in any type of C loop-like IOL. So you see several types of IOLs here, from Bochum, from Germany here, to Professor Burkhardt here. This is from Egypt, from Alexandria. This is for Dr. Noguchi in Japan, which is using several types of IOLs. And just I'd like to show you here the main results of this long-standing study in Alexandria by Professor Ahmed Al-Masri, which you see that we have quite stable, let's say, follow-up in all parameters. I mean, refractive, anterior chamber depth, and on. The pressure of the eye, the IOP is normal. And the major here point that we have zero PCO. This is the here cases that come close now to 2.5 years follow-up. And in the comparative group, on the same study center, you see that the PCO comes over the time increased by 10 to 15%. So the major goal, let's say, of the ring goes to avoid the PCO, of course. But as I said, there are many other features. On this video, you will see this standard surgery from Ahmed, which is here, I think. He's a very good surgeon. Thank you. Very simple to put the ring in the capsule. He is a master of that. And then you can flush in the ring any type of C loop like IOL, and it's very nice to lock the IOL in the center. The future of the ring, of course, is also the exchangeability. This is a very nice video also from Ahmed that he was exchanged an IOL. This was a single optic IOL in the beginning, and then the patient wanted to have far near vision, and he removed the first IOL and put an EDOF IOL after 3 months. And of course, the patient was very happy because the final result was, from the refractive point of view, absolute close to zero. And with the EDOF effect, he was very happy having an extended of focus in this case. And you see that the procedure is straightforward because we have the ring in the periphery. You can change anytime you like your IOL. So I like also to show you here this is so here I have also another video which I show you from Professor Noguchi from Japan, which has used several types of IOLs, but this is a very new IOL. He put the ring. Again, the procedure is straightforward, very simple. The additional time you need to put the ring based on Ahmed's studies is about 1.5 minutes, longer than the normal cataract. You see, you can easily rotate the ring inside the capsule and place the ring in the orientation you like to put the ring, of course, because sometimes you like to put the toric IOLs in this case. But in this particular case, it's very important because he is using the A-Sphera IOL, the ICA they call it. This is a pinhole IOL, it's a new design. In this particular case, you know, the pinhole, as you know, has to be centered very precisely on the center of the optical axis. Otherwise, it doesn't work very well. So the centration of these lenses is very, very important. So Bausch & Lomb lately bought this technology, and they are now, of course, very much interested to see how this can combine with a ring. This is another case for the vitreoretinal guys. A vitreoretinal guys has a patient who has been treated with a silicone for retinal detachment. He developed his very dense cataract, and then he wanted to remove the cataract, and to remove the silicone, they put an IOL. So the problem was, of course, what's happened when you remove the cataract and how you preserve the capsule in order to make the rest of the surgery. So he decided to use the ring. You see, he removed the cataract. He will flash the ring in this stage inside the eye. Again, the ring is opens very slowly. This is acryl, by the way. This is very, very simple to use material. The same material we use for the IOL. So normally, to flash in the capsule is very simple, but he wanted to make some more, let's say, manipulation. So now the ring is in the middle. Now what he's doing a posterior capsulorhexis with a ring in the eye, which is very safe to do that because the capsule is stretched and you don't need to have to make special maneuvers. What you see here is the silicone. For the previous vitreoretinal surgery, the silicone is floating up. Now what he's doing, he went through the posterior capsulorhexis. He aspirates the silicone comes up slowly. So, I mean, the ring is still there, it's very stable. And of course, when he removes everything, you see very nice also the posterior capsulorhexis, and it's very simple to flush the IOL in the eye. So the trick here is very simple because all you need is just to clip the optic of the IOL on the clips. I mean, you don't care what's happened with the loops. The loops are going somewhere in the periphery, in the ring. But in the middle, the only you do is just you plug down a little bit the optics, and it's easy to block the ink. This is another case. I saw some, let's say, more extreme cases. This is happening again, this is an ICL, a phakic IOL. This is a multifocal one. This is not an ICL, by the way. This is an Indian company who is providing this type of multifocal phakic IOLs. And then develop the cataract, and then it has to be removed. And in this case, you should, of course, go through to place your ICL in the anterior chamber. Of course, you have to be careful with endothelium. So you put some more Hilon in the front. This is the manipulator I have designed to move the ICL around. This is calling the Pallikaris manipulator. Osama, you forgot to put this invention in your slides. Manipulate. So, to remove this type of phakic IOL is very simple because they are very soft. You have, most of you have already, I guess, some experience. You pull out, then you wait for a moment, take a second forceps, because you don't like to tear, of course, the ICL and remain the half inside the eye. Such is out. So then, capsulorhexis. I don't have any video to show on pediatric, but we have done a few cases also with pediatric, and I think this is the most challenging, probably, indication for the ring to put in pediatric cataract. Ahmed has done a few pediatric and also Bochum. Ahmed is very happy with pediatric, he's there. And also Dick in Bochum. Bukar has done also another cases, and he's also very happy. This is just a normal then cataract surgery, aspiration, clean up the capsule, and again you see here how easy it is to flush the ring inside the capsule. I mean, the trick here is that the ring opens very slow, which makes sense. I mean, you have time really to manipulate the ring while the ring is inside the capsule and go on the right position. So important is that the tube, the top of the tube has to go inside the eye in the middle of the capsular axis. You see, you do very slowly, you observe, and you have full control of what's happening with the ring. Then you push down here at that point, and the ring is coming back very nice in the center. And again, you put your IOL. And of course, as I said, then you can easily, this is a multifocal IOL that you see here. At the end, you can easily rotate the ring in the direction, in the final, let's say, position you like to put your IOL. So you make some more rotation here. You can rotate as much as you like. I mean, the ring is rotating inside the capsule very easy. Okay, I mean, this is the idea of the ring, and everybody who's used the ring is very enthusiastic about it, and probably Ahmed can make a comment on it because he has most experience with that. And finishing my talk, I'd like to announce here that we decided to restart our international mini fellowship program we had already in the past. I think Uzama was one for the first day came in Crete probably 20 years ago. And we were doing in two modules. One is by e-learning with about 15 to 20 hours. And the other is on hands-on training for 3 days in the University of Crete. So this course, by the way, has been sponsored for the Iraqi doctors from Cooper, just keep in mind. And you see here the faculty, there are many people you know already. Some come from this area, the other they are worldwide known, let's say, experienced people. And everybody can join, of course, this course. And here there are the topics. This is an advanced course, by the way. So we are not going to deal too much with normal, let's say, procedure like PRK, simple, myopia case, whatever. We like to go much deeper to understand what is the success, or how we have to do a very successful surgery and personalize any treatment. I believe in my life, in my experience, that every person is a different case, even in the refractive surgery. It's not so simple. And today, the biggest problem is that any doctor can go in a machine, push the button, and say, I correct 3 diopters of myopia. But it's not so simple. Any different person is a different case all the time, and regularly you don't have so much problem, but when we have a problem, we have really a big problem, because there are healthy eyes. So we're going to deepen a lot in this course on this type of, decision-making, let's say, tools. And finally, I'd like to invite you, it's close by Athens, in June, of the Aegean Cornea in the end of June. Thank you very much to invite me, and I'm happy to be here.